Hello, everyone, and welcome to the 9th webinar of our webinar series for the European Public Health Conference. It's our Sailing to Lisbon 2024. We're roughly a month away from the European Public Health Conference here in Lisbon, and this has been a very intense webinar series. We've had a lot of the main topics of the themes of the conference being discussed here, and I'm happy to have today another set of wonderful speakers to share with us their insights on their views for public health. We're nearing capacity for the conference, so tomorrow we will be closing registration for the full registration, so for the 3 days of the conference. We still have room for the last day of the conference on Friday, and also for the pre-conferences day. And I'd also like to invite you to come to the Lusophone conference, which takes place on the Monday and Tuesday, so 11th and the 12th of November. So if you're planning to attend the conference, today is a day that you should register if you're planning to come for the full time of the conference, since we're closing the registration for the full meeting tomorrow. So please don't forget to do so, because otherwise we won't be able to host you for the full length of the meeting. Lisbon is a wonderful place to be, and we would like to share this video. It's a production with 20 fun facts about Lisbon. So I'll briefly share the video, and we'll be back with you soon. I hope you enjoyed the video. We're looking forward to have you back here in November. So if you haven't booked your travel yet, please do so. And bear in mind that the same week as the Public Health Conference, there will be Web Summit in Lisbon. So we have 70,000 people coming for the Web Summit. So accommodation might be difficult to find. So if you're coming, do book your accommodation in advance. I won't hold you from the webinar. I'm going to invite Andrea. She will be presenting the webinar. I'll just like to add that at the end of the webinar, we'll have the quiz, the usual quiz, where you'll have the chance to win an entrance for the dinner and dance at the conference in November. And for the person with most points will win an entrance. And also we're having the final two webinars, so it's today and the next one, where people can accumulate points towards the free registration for the conference. And it's neck and neck for the top participants. We'll show you the how it is now, points-wise, and we'll be looking forward to the quiz. So stay tuned till the end. I'll now hand over the floor to Andrea. Thank you so much for organizing the webinar.
Thank you, Ricardo. So my name is Andrea. I'm part of the scientific committee of our conference, and I'm also a public health medical doctor at our National Institute of Health and an assistant professor at the National School of Public Health. And I'll be co-moderating this session with Baltazar Nunes, who will join you in a minute. So it's my great pleasure to present this webinar where we will reflect on how advancements in epidemiological methods and data might support or challenge decision-making in public health. So we'll start by an overview of potential data sources to exploit in epidemiological studies and assessments, and we'll then delve into modern time series methods as a way to assess potential public health interventions and public policy. Finally, we'll end this webinar with a reflection on how existing evidence might be used to support public health planning and decision, and also existing challenges. So each one of our guest speakers will cover these topics. You're more than welcome to ask questions. We'll reserve your questions mainly for the discussion towards the end. And with no longer ado, I'll call now Heidi Rischel from the Norwegian Directorate of Health, where she's a senior advisor, to reflect on health data, existing health data to support public health decision. Thank you, Heidi. The floor is yours.
Thank you very much. I assume that if you can't hear me, I will be told very soon. If not, I will just start talking. The Norwegian Directorate of Health is my new workplace. I know some of you from my old workplace, the Norwegian Institute of Public Health, but we are at the same political level, and I'm very pleased to be working at a place that is more policy related now. My talk will start with telling you something about the Norwegian health system, about the Public Health Act, about how the public health profiles are one of the tools for data-driven decisions at central and local levels. I'm going to talk a bit about what lies behind these profiles, and I'm going to end by talking about planning, how to plan, about the local obligations that are the way that our decisions are supposed to be made. Now, Norway is a very long country with a very small population. There's only 5.5 million of us, and we are organized into 11 counties and 356 municipalities. And I'm going to talk most about municipalities because the municipalities is where public health and indeed all health starts, and that is where people live. Most of us live in urban areas, and the population, like the rest of Europe, is aging. The health sector is a little complicated, but if you look at this slide.
Heidi, sorry to disturb you. We're not seeing the slides go by. We're just seeing not the presentation mode.
This is very strange because you can't see anything with the health sector on it now.
Now we are, but it's not in the presentation mode.
Okay, should I start from the beginning?
Well, if you could, can you click on presentation mode so that we can see the full?
Presentation mode is on.
Okay, so then you need to reshare the screen so that you share the window for the presentation slides.
Okay, I will stop screen and I will share screen. Thank you. And I will.
And share the window where we have the.
I'm trying.
Yes.
And now I can't see the screen, but can you see it?
Nope.
Oh, delightful. Nope. We shall manage.
Yes. Yeah, we'll do it.
Okay, I will stop sharing my screen. I will start sharing my screen again. Can you see my screen now?
Yes.
Excellent. What happens if I do this? Can you still see my screen?
Perfect. Now it's perfect. Thank you.
Okay. Well, in that case, I will assume you heard my agenda and that at least some of you know something about Norway, which is a very long and large country with a very small population. Most of us live in urban areas. There's 11 counties divided into 356 municipalities, and I'm going to be talking most about municipalities because that is where we live. And this is where I stopped, so I will resume here. The health sector is organized in a rather complicated way. Above everything else, there's the parliament and the government, which is a part of the parliament. And under the government, and in fact, led by a minister of the government, is the Ministry of Health and Care Services. And right under the Ministry of Health and Care Services, there are many subordinate agencies, including the Directorate of Health, where I live. And we are advisors to the municipalities, and I'm going to say a little bit more about that. Our mandate is to improve the health of citizens and the community as a whole through targeted activities. We have both an advisory role directly towards the municipalities and also towards the whole system. We have a legislative role. We are supposed to be implementing any welfare and health policy going. And we have an important role regarding emergency response. When it comes to the municipalities, their main responsibilities are nursing care, everything to do with substance abuse and mental health, public physiotherapy, health stations for pregnant women and young children, school health services, healthy life centers, and where most of us meet them, the general practitioners scheme. Everyone in Norway, or just about everyone, has a general practitioner, and this is our gateway to the larger health system. And the municipalities are also in charge of emergency response. The Public Health Act of 2012 has as its main purpose to contribute to development in society that promotes public health and reduces social inequalities. So social inequalities is already in the law. And this act of law is supposed to ensure that municipalities, county authorities, and the central government implement measures and coordinate activities to ensure that public health takes place, to facilitate long-term systematic public health work. And public health is here defined as the state and distribution of health in a population. So the remit is rather large. In 2011, 3 new documents appeared: the proposal for the new Public Health Act, the revised Municipal Healthcare Act, as well as a plan for health and care services. And altogether, these 3 plans ensure that public health is publicly committed. It's the responsibility of the whole society and is supposed to be evidence-based and systematic. And on the whole, everything is based on the Dahlgren and Whitehead rainbow, showing that everything is interconnected, and health and the health of the population is not just the responsibility of the health care services, which is part of the whole. This Public Health Act applies to everyone involved with it. And local and regional levels are the key stakeholders, and we are supposed to support them at the national level where I work. Municipalities are responsible for doing continuous overview, having systematic public health work, and ensuring cooperation, both between the counties, between the municipalities, and also within the municipalities. All these municipalities are supposed to have sufficient overview of the state of health of the population and the factors that can influence this, based on information made available by central health authorities and the county, information from municipal health and care services, and knowledge about factors and trends in the environment and local community directly. And we here are mainly responsible for the first part, making information available as central health authorities. Then the municipalities have to take the necessary measures to meet municipalities' public health challenges, facilitate cooperation, as I said, and provide information both towards the individuals and the population as a whole. And the politically selected councillor has the overall responsibility. Again, public health is not just for the health sector. We have public data intended to help to fulfill this obligation, like the public health profiles, the childhood profiles, the different data banks, and the public health report, which I'm not going to talk about today. And systematic public health work is supposed to have an overview of health and status. It's supposed to be a continuous overview. And if you look at the circle here, we start with the overview. This should lead to planning. The overall goals and strategies from the plan are supposed to be implemented through policy and action plans. This is supposed to be implemented into measures. These should be evaluated, and this knowledge gained will again be added to the public health plan. So the overview, and this happy circle here, should make it possible for the municipalities to plan public health. And social inequalities in health should always be a part of everything that happens, health in all policies as well. The public health profiles used to be made by the Public Health Institute, but the whole crew was moved by New Year's to the Health Directorate, where I work now. And these public health profiles have 4 pages, main features, more information on specific subjects, and the public health barometer, which is the most popular and most complicated part of it all. We make these on a municipal, city district, and county level. And these profiles contain easily accessible information about population health. We interpret statistics so that people who are not statisticians can also understand what is going on. We give it a visual depiction of what is going on. And these specific annual topics, well, this year the topic was active aging. And on the screen, I'm showing some of the other topics we've had. And having a topic means that we try to select specific indicators on that topic. The main sources for these profiles are the registries, which in Norway are law regulated and person identifiable, and also some surveys. And the different registries go from the medical birth registry to the cause of death registry. So in essence, the different registries follows the population from birth to grave, including quite a lot of information. This is what the barometer looks like. It has around 34 indicators, and it shows the municipality or county or city district compared to the country, other municipalities, the spread within the county, and whether something is good, bad, or neutral. Good, green, bad, red, neutral, yellow. And these are directly linked to the data bank. So if you take one up on your screen, they are easily downloadable in PDF form. You can click directly into the different data banks. This is the explanation about green, red, and yellow, and some other things. But behind these public health profiles, we have the data banks. At present, there are two. One of them is available in English, and we are going to merge them, but things are taking a little longer than we were expecting. The municipal data bank looks like this. NorHealth looks like this, and that is the one that is available in English as well. And they have the same user interface, so if you know how to use one, you can use both of them, as well as the more specialized data banks at the Public Health Institute. And using the data banks, you can end up with things like this. Here I'm looked at the municipal data bank, and I picked out all the municipalities in Møre og Romsdal County for a 10-year span, showing the percentage of births of children weighing more than 4.5 kilos. And you can see the spread is quite wide, from 6.9% to only 2.7%. So this is something that the local municipalities are probably keeping an eye on. Or we can look at national data. Here I have smoking for adults, men and women aged 16 to 24 and 45 to 64. And as you can see, it's all gone down quite a lot over the years. And you can also see that among young people, smoking is now quite unpopular. This is something we're quite happy about. There are metadata for each indicator, which defines it, describes the population, says something about the unit of measurement, gives the data source, information about how data is collected, and something about the data quality. And there are also links to other articles and other sources of information. And if you are using this tool set and you are working for one of our municipalities, you can use them when you are planning how to plan, following the legal obligations of the counties and the municipalities, because planning is really a key tool. Without a plan, everything is going to be completely random. If you have a good plan, you can use that to promote health and counteract social inequalities. And many laws are linked to these plans. And in fact, the municipality must link the public health work to the municipal planning strategy, not just a health strategy. They need to have an overview, and they need to use that for the planning strategy. They must assess population composition, childhood environment and living conditions for all, physical, biological, chemical and social environment, injuries and accidents, health-related behaviors, and the state of health of the population. And the public health profiles and the data banks are some of the tools used to do this. In addition to public statistics, the municipalities must use their experience, and very often the counties have conducted public health surveys with help from the Norwegian Institute of Public Health to provide data at a local level. This knowledge base must identify the most important challenges for public health in municipalities, and these should be discussed in the planning strategy. And then you have a plan and you make health impact assessments. When you're using the different information forms and the different tools, then you try to identify local challenges. Are there red dots? Are there green dots? A red dot may not necessarily mean that something is bad. It means that something is worse than the average for the country. But if you look at developments over time, and to do that you must go into the data banks, you can see that something has been improving over time or deteriorating over time. So you must always look at the data banks, not just the profiles. You must try to identify problem areas, not just geographically, but also problems regarding specific health areas. If you have bad statistics in one specific field, say you have a large percentage of the population taking medicines against cardiovascular problems, if you have a lot of people hospitalized for cardiovascular problems, if you have a lot of deaths for cardiovascular problems, you probably have a cardiovascular problem. And then you need to learn more about this and find out what your municipality should be doing. Following developments over time this way, you need to discuss and collaborate both with all the different kinds of authorities and people with information in your own municipality and across municipalities. Many municipalities are very, very small. They must collaborate across because otherwise they will not have enough people to do the work. And once interventions have been identified, They should be followed. Effectiveness needs to be checked. What is important is a multi-pronged approach, not just doing one thing, but looking at the problem from many different angles and finding out which of the different municipal sectors can help you. To use the existing structures and working across these sectors, make plans, follow plans, and evaluate plans. And that is my main message. For good public health work, based on available information, you need to make plans and you need to follow them. Thank you.
Thank you very much, Heidi, for this presentation and also for this so important message that you let us at the end of your communication. We will leave the discussion to the end, and now I will move to the next speaker. That is Professor Antonio Gasparini from London School of Hygiene and Tropical Medicines, that we're going to talk about time series methods to evaluate public health interventions. Thank you very much, Antonio. The floor is yours.
Can you hear me? Okay, brilliant. Thanks very much for your invitation. My presentation is more about, let's say, study designs and statistical methods applied for public health, and in particular focusing on time series methods. And in this presentation, I will try to focus on recent advancements and, let's say, extensions about these methods. Now, the motivation and probably the opportunities for these advancements are coming from the availability of new data resources and data frameworks. First of all, on health data, thinking about administrative data sets and also traditional population-based cohorts now extended to cover big populations, but also in particular by the extension to methods to map, let's say, the outer world and the environment, and in particular getting environmental data from many different sources, including, for example, reanalysis data or remote sensing. And in addition to that, the possibility to link all this data with individual level contextual characteristics from different choices. Now, part of this revolution, let's say, comes from the availability of new data resources and technologies. I mentioned a few. As I mentioned before, through reanalysis data, we can now attach measurements, for example, to any kind of environmental measurements to any part of the world, probably not just today, but also back in time and also projected in the future. Through remote sensing, we can map them more than through many different instruments, measure many different environmental factors and topographical features, more on individual level. Now with smartphone technologies, we can have a real-time collection of information at the individual level that through geolocation, we can match again through time activity patterns and therefore reconstruct accurate, let's say, maps and profiles of exposures, outcomes, and many other factors at individual level. Now, how this can benefit the time series model, I don't want to focus here on technical details. Basically, time series methods are available since a long time ago. The main idea of how they work is through this kind of temporal decomposition of the series in which we can pick specific signals and in an epidemiological perspective, create associations between specific exposures, in this case, in here, algebraically define X, and through a function F, measure the so-called exposure-response relationships with some outcome Y, while at the same time controlling for temporal factors plus other measurable characteristics. Now, this, as I said, this design exists since a long time ago, is powerful. Let's say design means that we can smooth out basically trends, etc., and capture signals which will be very difficult to capture otherwise. So we have, in time, developed these filtering methods in a way that you can see here through smoothing to, in a way, account for these temporal trends that can be very complex, and also, in addition to that, establish complex associations, for example, on an example here through distributed lag linear and nonlinear models, meaning that we can capture relationships that are not just nonlinear, but are also delayed in time. Thinking about, for example, effects of air pollution, temperature, or other environmental factors, these are not limited to the same day exposure, for example, but we can see that they are also delayed in time. Now, the time series framework allows a very fine characterization of these complex associations, both non-linearly and in time, in terms of their delays. Now, nowadays, the time series is mostly applied in environmental epidemiological studies and, let's say, public health impact assessments through a two-stage design. What is the idea here? That, of course, I can collect data for many different locations, and instead of running a single model for all the location, I run specific time series model in each location, and then I pull together the information across locations in a second stage meta-analytical method. Now, while this is powerful, first of all, it allows still the characterization of local effects, but at the same time, it allows comparing, say, risks and impacts across large population, also potentially accounting for heterogeneities and differential vulnerabilities across the population. Now, this framework is known and has been established in the last decade through intense methodological development. What I'm focusing on today is first a couple of examples of in which we have extended this framework further on many different aspects to run analysis at a European level, for example, for the first example, and the second example, a small area level for analysis focused on the UK. Later, I will present another design in which we can see how we can use time series method also for individual level analysis. Focusing on the first example, we are discussing these published studies in which we wanted to, through a two-stage time series analysis, evaluate the health impact of temperature, both heat and cold, across a representative set of cities, all the cities with more than 50,000 inhabitants in the EU in the period 2000 to 2019. So we apply this time series mortality data in actually more than that is 238, I think, locations, but also collected data for the whole 854 cities. We link these to a daily temperature from a gridded database obtained for Copernicus, and we also link the city level characteristics from Eurostat. And we use the information on these 238 locations to extrapolate the associations across the board. Now, in this analysis, we applied a series of extensions. The first extension was to being able to measure age-specific exposure responses, accounting for vulnerability factors, in particular allowing heterogeneity in the exposure response relationships, extrapolate the results to cities for which we don't have mortality data, and also derive effect summaries and standardized measures that are easily used for public health purposes. Now, I don't want to discuss about details. One of the difficulties we had was allow accounting for the effect modification for many different characteristics. You can see them listed, all of them on top, going from population density, GDP, education, and many other infrastructural characteristics. First of all, we condensed this information through partial least squares reduction, obtaining these limited set of components that can explain differential vulnerabilities across the region. And when applied to this relatively complex statistical framework, we could derive age-specific pooled exposure responses, meaning these curves characterizing risks for heat and cold, as you can see here, and also identifying a so-called point of minimum mortality, differentiated by age, and this, of course, consistently with the literature, showed much higher effects and risks in the older populations, in particular in the 85 older. But more than this, we could characterize differences across the population in terms of impacts. In here reported at age and country-specific excess rates for both heat on the right-hand side in red, and also cold on the left-hand side in blue, and obtain a complete map, let's say, of the impacts, in this case reported as standardized excess death rates across Europe, showing significant differences in impacts across the geography of Europe, with some places, for example, East Europe and for cold, and Southern Europe, in particular for heat, which are more at risk. Now, another example in which we apply this framework is a small area analysis. Instead of characterizing risk across the whole Europe, we wanted to characterize the risk a small, let's say, a small scale across England and Wales, covering again the same period and the population by using more refined data, in particularly 1 kilometer grid temperature data across the whole geographical domain, and also small area indicators, aiming to be able to define fine scale associations and vulnerability indices at small area scale. Now, to give you an idea about the geography, England and Wales are divided in 348 local authority districts. You can see the map on the left. Each of these districts, and on the right, you can see a focus on one of these districts, which is the borough of Camden within London. These are divided further in administrative areas called LSOA, lower super output areas, which are very small census-based areas, including approximately 1,600 people here in each. Now, the idea is to be able to characterize impacts of heat and cold in each of these LSOAs. And just to give you an idea about this, the scope, there are 35,743 across England and Wales. Now, we applied more or less the same approach, trying to use area level characteristics to define differences in risk for heat and cold. We apply a similar methodological framework, analytical framework, and we derive therefore age-specific pooled relationships. But more importantly, we were able to characterize these relationships differently for each of these thousands of small areas, and from there being able to compute impacts in terms of LSO-specific heat-related standardized rates. Of course, the same we can do it for cold. And in particular, the map on the left show the big picture across the whole country, by the maps on the right show a focus on Greater London and on the borough of Camden, showing that there are significant differences in impacts also at small scale. Now, the first part of my presentation is very quickly introducing how we extended this time series framework for individual level analysis, thinking about following individuals in time instead of just an aggregated time series for the individuals. And this idea underpins, in a way, the creation of this new design called case time series, in which we can, let's say, derive individual level profiles and subject-specific series to apply the same time series framework at the individual level. Now, the idea is that the modeling framework stays more or less the same. The only difference is that you have a stacked series of individual series attached to each other, and therefore you can measure, able to measure everything at the individual level. Now, an example is the application of the smartphone study, because as I mentioned before, a smartphone can be used to follow up individuals, collect information on a daily basis, and recreate these individual series for these subjects. In particular, this was a study in Tasmania looking at effects of different environmental factors, in particular pollen, pollution, PM2.5, and temperature on the risk of having symptoms, allergic symptoms. And in here, it's shown specific data from one of the subjects included, for whom we were able to reconstruct completely the history of daily symptoms, allergic symptoms, but also connected with the geolocation to reconstruct the individual level exposures to all the pollutants, again showing that it's possible to derive individual level exposure response relationships for all the subjects, showing complex patterns of associations with pollen, PM2.5, and temperature. Now, I conclude by saying that the field is moving faster. There is now a rich data setting through which we can apply extensions of tight series methods, applying in different settings, both large scale, Europe-wide, or let's say country-wide analysis, or also focusing on individual level analysis, especially with the integration with smartphone technologies. And of course, this will be possible also to increase both our ability to detect differential vulnerabilities in population, but also different etiological mechanisms applied to occurring in a way for specific associations. I leave it with this slide in which I included some links with articles, tutorials, and R code, and a couple of courses we are running explaining and teaching all these new methods. Thanks a lot for your time.
Thank you very much, Antonio. This is impressive work, really, and all the data that you make also available, and all the code, I think is very relevant for all the groups also to work more. I will now pass to the next, and I'll move the discussion to the end, if you don't mind. I will now ask Maria João Gregorio from the General Directorate for Health in Portugal. She's now the director of the National Program for Promotion of Healthy Heating at the National Directorate of Health. Maria João, thank you very much for coming. The floor is yours. I will not take more of your time. Thank you.
Thank you so much, Baltazar, and good afternoon to everyone. And thank you for inviting me to this webinar. And during my presentation, I will try to explore this topic, how we can use evidence to support public health policies, decision, and planning. I think that I think that we all agree that there is a gap between evidence and policy action. During this brief presentation, I will try to identify why we, from the science side, are probably failing, and what are the potential solutions to close this gap and increase the impact and policy uptake of the evidence. To enable a more effective influence of evidence in policy action, I think we need to understand the process in which the policy making takes place. And in theory, this is the policy cycle process that is composed by 5 different sequential main steps, from the problem identification to monitoring and evaluation. I would say that academia and researchers have been more focused and efficient in generating evidence to the first step of this policy cycle, and probably and unfortunately this is not the most important and challenging step of the policy cycle process. And I can share a particular example of what I am trying to explain. For example, when it comes to the influence of food marketing to children, there is quite strong evidence on the nature, extent, and impact of food marketing to children, in particular in children's food behavior. But the certainty of the evidence regarding the effectiveness of the policies to restrict food marketing to children is very low. So here we see the differences between the level of evidence that we have regarding the problems and the evidence regarding the solutions to solve the problems. My first point is that generate evidence for problem identification is of course not enough to promote policy action, and we should go further and be aware that for policy action we also need to generate evidence to show the effectiveness of actions to solve the problem. We also need to have evidence to guide effective implementation. That is how it can be done. And we need also to show cost effectiveness, and we need to present some data regarding the feasibility of the policy actions and even how they may save money. And if we look again to the policy cycle process, but now using the lens of practices and real life, it is possible to understand that in real life the policy cycle process is much more complex, and it is often non-linear. And for example, we know that sometimes we have different steps that might happen at the same time. And we have other, for example, such monitoring and evaluation that may be completely skipped. And this is, of course, one of the challenges. So in practice, it rarely happens according to a formal cycle, which of course represents a challenge in terms of the evidence needed to promote policy action. And in this policy process, and we can see according to this slide that this policy cycle is even more complex if we consider that there are a very broad range of stakeholders that are involved in the policy making process, and they try to influence the policy making process, and some of these different actors and stakeholders engage with the policy makers, and they try to put their own agenda to influence policy making process. And another issue that I would like to highlight is that connecting policy making with scientific research is not an easy task, because the scientific and policy making communities often operate in different ways with distinct values, languages, and time scales. So the meaning of evidence is different between researchers and policymakers. And we know well what evidence means for researchers, but we know less well what it means for policymakers. But for policymakers, evidence needs to be relevant for policy action, of course, timely, and should be based on a clear message and response, and it is framed by narratives. And when it comes to the differences between policymakers and researchers, I would like I would say that differences in time scales are quite relevant, and policy often moves quicker than science. And considering the current political instability, and nowadays the time of policy is even shorter. For example, in some countries like in Portugal, we are having shorter political cycles when comparing to the common 4 years of a political cycle. Sorry. And since I am somehow criticizing this science approach focus on problem identification, I will not waste more time identifying problems. So during my next slides, I will try to provide some insights on how to bridge the science policy gap. And my first note is that we need to be aware that for policy making, a broad information type of data is required. And as previously showed, researchers and policymakers often speak different languages, and have different conceptualizations of the evidence, and to support the policy adoption and implementation, policymakers are mostly interested in the context, and in the implementation details that are not often covered in sufficient detail in the scientific evidence. And when we talk about the evidence related with the context and with the implementation process, we are talking, for example, about data on values, resources implications, acceptability by the general public, but also by the different stakeholders, and also information on the feasibility. And the WHO, as part of the guidelines development process for policy actions implementation, have recently started to conduct reviews to identify these contextual factors that may affect the implementation of policy interventions. And this type of evidence is called by the WHO as the contextual factors. And considering these different contextual factors, I would say that data on values and acceptability seems to be really important and relevant for policymakers, and the values are related with the importance that people assign to the results that are associated with the policy intervention. And for example, the European Commission is now working in this area and have published this guide for policymakers, recognizing that the EU policies need to take into account and reflect the values and concerns of citizens. And here I have a concrete example, and I bring this type of data regarding the acceptability by the general public in Portugal regarding different nutrition policies. And now in Portugal, we are trying to use this kind of data to support policy decision making, because in general it's possible to see a good support from the general public regarding the different policy actions that we are implementing in Portugal. Another relevant issue is data showing what works and what do not works. And for that, providing some examples regarding other countries is important, and share experiences that some countries have successfully implemented similar policies, demonstrating that policies, again, are acceptable to the government and feasible to implement. So this is also information that is really important for policymakers. And since implementation is most of the times the big issue in policy action, I believe that we should consider more the potential of the implementation science and studies to try to close this gap between what we know and what we do in practice. And this type of science is important because it addresses the contextual factors that matters to policy action, like the barriers and facilitators to improve the use of evidence to support policy actions. And I would also say that to improve the impact of evidence for policy action, we need to change the way we use to translate evidence to policymakers, and probably the format in which we engage with the policymakers. And for example, policy dialogues are now a promising approach because it promotes higher levels of interaction between researchers and policymakers, increasing the likelihood of research evidence being used. And again, a practical example in this slide, there is an example of a policy dialogue that was organized by the General Directorate of Health here in Portugal. And this policy dialogue was organized to discuss the implementation of policies to restrict food marketing to children that were successfully implemented in Portugal in 2019. Another tool that can be used for a better translation of evidence to policy action is the development of policy briefs. And these policy briefs are short documents with a content and structure specifically developed for policymakers, and it includes information, for example, regarding the different policy options that should be considered to tackle the problem, but also the barriers, the facilitators for implementing each policy action, and also the strategies that can be used to address the main barriers. And the last note that I would like to share during my presentation is regarding the importance of the advocacy work, and considering that policy decision is influenced by several stakeholders and by different competing interests. We should also consider that we need to advocate and participate more, in particular in some consultation process, because the participation of the academia in consultation process for policy action is still low. And here we can find the data regarding a consultation process promoted by the European Commission regarding the revisions of food labeling the rules, and we see that academia represented 4% of the contributions submitted to this consultation. And we can see and observe the same results for the national context. This is the public consultation to the National Program for Healthy Eating Promotion, and it's possible to see again that the representation of the academia is similar with the previous example, and it is possible to see that the food private sector represented is here represented as the higher percentage of contributions submitted to this consultation. And since the successful engagement in evidence-based policy making requires pragmatism and the need to use more adaptive and flexible research approach, I think it is legitimate to raise this question: how far should we go to bridge the gap between evidence and policy? And this is really a challenge and probably a paradox, because as scientists we are not comfortable in being perceived as policy, and neither to leave behind some of the main principles of rigorous scientific evidence. And to conclude my presentation, I would say that we still need to bridge the gap between science and policy making. We need better science for policy action. We probably need to reframe the type of evidence that we generate to promote policy action in order to be able to engage in the complex, non-linear system in which political decision making occurs. We need to improve the format in which the evidence is transferred to the policymakers. We need to consider that implementation is still a big issue in terms of policy action. So we need more implementation science, and we need to be aware that policy implementation is influenced by several different and competing interests. So we need to advocate and participate more. And thank you so much for your attention and time. Thank you.
Thank you very much, Maria João, for this so nice presentation. I think we don't have any question on the chat, but I will ask Ricardo if you can put also ID and Andrea, so we can just have a small group discussion with 10 minutes that we have left. Heidi, I would like to ask you something regarding all this data that is being collected, and also related with this presentation from Maria João. In those surveys or in the data that you are collecting, are you also collecting data about implementation of the policies, on the acceptability of the policies by the population? Can you also monitor this component of the intervention? So what is the perspective of the population related to the policies, the health policies that are implemented in Norway?
There have been surveys looking at that, but they are mostly on the qualitative side rather than the quantitative side. About a year ago, we were looking at how and what the central authorities could do to help municipalities to implement the central policies about nutrition, for instance. And we did that both with a survey with questionnaires and also with qualitative interviews. And this mixed methods approach, using both a survey directed towards all the municipalities and qualitative questions directed towards a smaller selection, where we try to make big, small, different parts of the country, etc. And that really helped us to see how we can support policies and also what they think about policies. But making policy indicators is hard. And you don't always know which questions you want to ask when you start asking them. Does that cover what you mean?
Thank you so much. No. Yeah, it was perfect. Thank you very much.
Thank you also, Heidi and Marie-Jean, for your very interesting presentations. Unfortunately, Antonio won't be able to join for the Q&A session, but we've seen that increasingly the sources of data and methods available are getting more and more complex on the one hand. On the other hand, we need to make this liaison between the scientific knowledge and the decision process. So Maria João highlighted some potential solutions, but my question is, who is responsible for implementing those solutions? Because as you've mentioned, this ranges from the research questions we are asked to then how we disseminate our results. So who is up to implement those solutions you suggested? And also, one gets the impression that it's all on the hands of the researchers and the technical, those with technical responsibilities. Don't policymakers have their own responsibilities as well?
Of course, I agree with you. This is not only the responsibility of us as the science side or as the technical level, because we have also the technical level that is responsible for this work to support the policy development and the implementation. And of course, the policymakers should also have their role, and of course we need to have both, trying to bridge this gap. But of course, since I am from the science side and from the technical side, I am more focused in what we can do to try to improve this connection, and try to improve the use of evidence for policy making, because I think this is what we want as a researchers, is that our evidence is used to improve the health of the population. So this is our main objective and outcome. So I think we need also to have our role.
This interplay between indicators and policy, I think, is really important. You cannot have a policy unless it's based on indicators, that is, numbers. But on the other hand, if you don't have a policy, it's really difficult to find out what you're going to look for indicators on. And I think we need more interplay between the policymakers and the researchers. I myself recently moved from the science side to the policy side, and I noticed that what we really need to do is support local decision makers who have no scientific grounding whatsoever. We cannot expect all policymakers to have a PhD in anything. And a lot of them are politicians. They don't have that much education. We need to educate them, and we need to talk to them in their own language without being too scientific. And that is difficult. But I think things like the EPH conference is one way to do this, to have that communication and to have those very important dialogues.
Thank you very much, Heidi. That's once more a very fine conclusion. And I think also the objective of this webinar was also to bring together all these three perspectives: one about the data that we need, about the methods that sometimes are highly complex, but that need to be translated into information that can be used in the policies. If you don't, as both of you presented, if you don't have this cycle is not working, I think we are not doing our job. So once more, thank you very much for your time, for your thoughts, for your time availability to share your ideas and your perspectives. In the name of the ICC, I thank you once more, and I pass the floor to Ricardo. Ricardo, thank you very much also.
Thank you so much, Baltazar. I think it was really, really an impressive session. Thank you so much to our three speakers and also to our wonderful two moderators for hosting the session today. So thank you so much. I'll be looking forward to meet you at the EPH, just like Heidi just mentioned. And I try and remind everyone that the registration for the full conference is closing tomorrow. So we're reaching capacity for the venue in Lisbon. So if you haven't done yet, please register today. Otherwise, you might be missing out on the biggest conference, the biggest European Public Health Conference so far. So thank you so much to all five of you. And I'll now be moving towards the quiz, the usual quiz that we have at the end of the sessions. You have the link here, so please use this link. We recommend that you use a mobile phone to answer, and bear in mind that usually it's faster. The questions appear earlier in the app in your mobile, then they will show up on the video because there's a short delay on the video. So do take care and make sure that you actually are aware of that delay. So please don't forget to be fast, because faster answers are that get more points. So don't forget to be fast on your answers. So please, you can use either this QR code or the link that you have here in order to register for the webinar. Sorry, for the quiz. I'll remove this now. So let's see the answers. Okay, none of them got it right. So UFA owns the European Journal of Public Health. Okay, so we remain at the same standing. So Gustavo is leading and Christina is second. Let's see the sixth question. So how are the EPH conferences in UFA linked? The EPH conference was started by UFA. They're not linked. The EPH conference established UFA in 1992, or they're both based in Brussels. Seems like an easy one to answer. Okay, everyone has answered. Let's see. Yes, the EPH conference was started by UFA. Let's see. So Valentina is now correct. So we have Gustavo first, Valentina second, and Christina third. Let's see the seventh question. So what is the motto of the UFA strategy 2020-2025? So the current one. Is it analysis, advocacy, and action, scientific evidence, well-trained workforce, voicing knowledge, enhancing capacity, or capacity building and research promotion? Okay. So only one answer. It's voicing knowledge and enhancing capacity, but in fact, it's the AAA: analysis, advocacy, and action. So standings remain the same. Let's see the next question. Who is UFA's executive director? So this is UFA's, that's the misspelling. So it's from UFA. Is it Charlotte Marchandise? Is it Boris Van Horn, Jose Francis, or Nicholas Bishop? Who is the current UFA executive director? Indeed, it's Charlotte. So we had one correct answer. Let's see who got it right. Valentina. Oh, Valentina is now leaping towards the lead. So we have Valentina first, Gustavo second, and Christina third. Let's see the next question. Only 4 questions remain. How many individual members are there in UFA? Is it 10, 15, 5, or 7? Okay, let's see the answers. It's 7, actually. So it's 7 individual members. So one answer correctly. It's Diogo. So Diogo joined in. So he's now gone into the 3rd place. Let's see the next question. Only 3 questions remain. So question number 10. How many pre-conference does the European Public Health Conference have this year? Is it 20, 25, 15, or 30? So how many pre-conferences will we have? A lot to offer on the 12th of November. Let's see the answer. It's 25, indeed. So let's see who got it right. Valentina. So she's now leading, 272 points. Gustavo is trailing behind at 174. Diogo, 92, and Christina, 63. Last 2 questions. So when do full registrations for the conference this year close? Is it today, the 1st of April? Is it tomorrow, or 25th of December? Remember to register if you haven't done so. Yes, it's tomorrow. Everybody got it right. So I hope you're already registered so you know that it's tomorrow, the deadline. So now it's the question of who was the fastest. Apparently, Valentina and Diogo were the fastest. And here we go for the last question. Let's see who takes the prize today. So, which literary masterpiece by Fernando Pessoa features the semi-autobiographical character Bernardo Soares and is set in Lisbon? Is it The Book of Disquiet, Coragem, Ode to Ricardo Reis, or the Maritime Ode? Let's see the answers. Yes, it's the Book of Disquiet. Let's see who got it right. So Valentina takes the prize. 3 straight answers. So congratulations, Valentina. You've won the dinner and dance prize. Don't forget to register for the conference. You'll only be able to enjoy the dinner if you are registered with the conference. Let's go towards the last event of today. So now we're going to draft an entrance for the dinner. So if Valentina is the winner, we'll actually I'll spin the wheel, and if Valentina wins, we'll spin it again to see who wins it. So let's see. Oh, okay. So we'll remove Valentina and spin again. Okay. Congratulations, Christina, for winning also an entrance to the dinner and dance on at the conference on the 14th of November. Don't forget, everybody who's won the prizes, you need to register to take advantage of your gala dinner entrance, your dinner and dance entrance. Okay, so last, we would like to ask you, what word would you use to describe this webinar? So please type in your answer. And while we wrap up today, so thank you all for watching the webinar. Really interesting insights from all the speakers. We'll be looking forward to meet you in Lisbon. I hope it was a useful webinar. Stay tuned for the last webinar with the quiz. So the last quiz will take place at the next webinar, because on the last one, we won't have the quiz anymore. So there's still 2 webinars to go. One of them will be the next to last with the quiz, and the last one will be where we announce the winner for the free registration for the conference. So thank you so much, everyone. We'll keep looking forward to host you in Lisbon in November. Thank you so much, and all the best for you all. Have a great week.